The presentation today is brought to you by the SDSMA Center for Physician Resources, and it's going to be on risk management. This program is brought to you in partnership with MMIC. Note that all lines have been placed on mute to prevent background noise. However, we will open lines up at different times throughout the presentation, so you may ask questions. You're also able to present questions through the chat line on your computer, so that is an option to you as well. With that being said, we want to be sensitive of everyone's time, and I'm going to go ahead and turn the presentation over to Robert Thompson. We'll interview himself, and he'll step us through the risk management process. Robert, to you.
Thank you. I appreciate the opportunity to speak with you tonight. I think that dealing with a topic that is growing more and more important in the physician office practice and in the clinic setting. This is a kickoff of a number of articles and presentations that will be over the next year or so, focusing on risk management and patient safety, particularly focused on the clinic side, office practice side of medicine. I've got a background in both healthcare and law, and have been in the professional liability insurance world for about the last 15 years, and it's a dynamic market that continues to change. And I think, as I mentioned, that this is an opportune time to start focusing on risk management and patient safety in the clinic setting, because we're seeing an increase in the number of professional liability claims coming from that sector. Traditionally, the majority of medical malpractice originated in the hospital setting, and in recent years, we've seen a significant increase in malpractice claims coming out of the clinic. So I look forward to working with the center and providing some education and assistance as we head down the path. With that, we'll go ahead and move into tonight's program on the risk management process. I see there are a couple of objectives that we laid out. We're going to talk a little bit about risk management and claims, give you an idea of what we're seeing from a claims standpoint. He's corporately based in Minneapolis, and we insure the vast majority of the Midwest, and we insure about 16 states now, and so a lot of our claims, the majority of our claims information will come from that Midwest area, so I think it gives us a fairly decent idea graphically as to the types of claims that we're seeing. And then we'll get into some reasons for conducting a risk assessment and talk about the steps in establishing an effective risk management program in the clinic setting. Talk for today, risk management and malpractice, claims environment. We'll talk about the major factors leading to malpractice, areas that we have seen that have led to claims, areas that can help you focus your risk management process and risk management program as you go through the process of establishing a program. We'll talk about the reasons for implementing a program, the four-step process, and then talk briefly about conducting a risk assessment in the clinic setting. To start off with a definition of what risk management is, and our definition at MMIC is that it's a style of practice to prevent and control patient injuries, malpractice claims, and malpractice claims losses, and we kind of look at that as a three-step retreating approach. First and foremost, avoid patient injuries as a first defense. First, do no harm. If you don't have a patient injury, there's no way that you can have a medical malpractice claim. Next on the list, and far and away the most important, is to prevent claims by establishing good quality relationships and open lines of communication with your patients. In 15 years that I've been dealing with professional liability, it continues to kind of shock me how often mal claims come to the root of relationship, communication, and bedside manner. And we'll talk a little bit about that tonight. And then as we get into 2014 and some more of the focused educational programs, we will actually have a program that deals specifically with communication. So that's the second retreating approach. It claims when you can, and the best way to do that is through relationship and communication. And then on the list, if a suit is inevitable, make it defensible, and that kind of boils down to one thing, and that's documentation. Make sure that we have the ability to defend a claim. There's nothing worse as an insurer than to have have it work its way through the system, and when we look at it clinically, feel that the claim is defensible, but then have our hands tied because of lack of documentation that makes it impossible for us to defend the claim. That basically is our definition of what risk management is. This slide talks about negligence and the four aspects needed for a valid malpractice claim, those being a duty, a breach of that duty, a causal relationship, and an injury. But focus your attention on is the last part of this slide, what we call malpractice plus, or the X factor. We've seen a change and a shift in the manner in which plaintiffs' attorneys pursue malpractice claims. This change has been happening over the last 5, 7, 8 years or so. And what the shift entails is the way that plaintiffs' attorneys are looking at malpractice claims. They're not as focused on the clinical side. They're not as focused on the clinical side of a patient injury. And where we have seen that shift is more toward the service side of medicine. So plaintiffs' attorneys are focusing on service lapses in practices and hospitals. And what we see is that lapse in service or some sort of lack in service is what is the deciding factor in a plaintiff's attorney actually pursuing a claim. And I'll give you an example. One of the biggest service lapses that we see right now are follow-up systems. So that's the loss of or replacement or somehow or another a lab or radiology or other procedure report disappears in the system. And what we find is that American tend to be rather forgiving of the clinical side of issues with malpractice. They understand that this is the practice of medicine. They tend to be very unforgiving of service lapses, and so they expect that the service side of medicine would be perfect. So if you do end up with a lost mammogram report, for example, and a patient sustains an injury because of that, they're very, very unforgiving in those instances. And what we find is that plaintiffs' attorneys often hinge their pursuit of a malpractice claim on whether or not there was some sort of service lapse. We also see that the value of a malpractice claim tends to expand and go up when there are service lapses. In talking about the claims environment that we're seeing today, claims frequency is stable, so that means the number of malpractice claims that we're seeing come into the system is about the same. There are indicators that frequency is starting to see a little bit of a rise, but for the last 5 or 6 years, we've seen a fairly steady decrease in frequency, and over the last year or so, it has stabilized. It tends to be cyclical, and the indicators are that claims frequency, so that number of claims will start to increase right now. That doesn't cause us as much of a concern as the severity issues. Severity has been on the rise, and we suspect will continue to rise, and that is that the dollar value of the claims that are working their way through the system is going up. What we expect is that X factor that I just mentioned, that this on service lapse will extend that severity trend. Here are some examples of what we see from the service side: failure to disclose, jousting, which is making negative comments about the care of other providers, basic patient and team communication issues, systems errors, and other basic service lapses. Is that solid risk management practices are your best defense to potential claims. So the things and the processes that we'll talk briefly about tonight are a great starting point in not helping your patients experience better clinical outcomes, but in also avoiding or helping to avoid the potential of a professional liability claim. This is an idea from a severity standpoint as to what we see. This is a nationwide statistic, but we're getting pretty close to it here in the breadbasket of the country. 1 in 4 jury verdicts exceeds $1.2 million. You can see some of these shock losses here: $20.5 million, $15.5 million, $17.5 million. And a little bit closer to home, I'm actually based in the Missouri area, so I tend to see a lot of these local claims. The Lewis County Circuit had 7 cases since the start of 2007 where the plaintiff was awarded $2 million or more. If you look at the date of that newspaper article from the Daily Record out of Kansas City, shows that it was only about a 15-month period. It was March 2008. Talking about 7 cases, dollars or more, in a 15-month period 5 years ago. We know with the severity trends that this is only the tip of the iceberg as to what we are probably seeing right now. Expect to see in the future. Professional liability claims have a unique problem related to them, and it's called the tail of the claim. The average length of time it takes for a professional liability claim to work its way through the system is about 5 years. And so the information that we're dealing with that we know that has come out of the system right now, those claims went into the system about 5 years ago. And so it's a pipeline. And so a lot of what we're looking at as to what we can expect in the future is speculation and best guess scenarios, just because of the length of time that these claims take to work their way through the system. These 2 slides will show you severity as far as the average indemnity paid by specialty. These numbers are actually 10 years old. The newer numbers indicate that you can take this number and just about triple it. So the average indemnity paid for a neurosurgery claim would be closer to $750,000. Now that'll give you an indicator too of just how much severity has driven in the past decade or so. We have seen, in addition to these numbers are provided by the PIAA, the Physician Insurers Association of America, which is a trade organization of professional liability insurers. And it interests me not as much for the numbers here, but by specialty to see who is in the top 10, who is paying most by specialty. And if you look here on the list, the family practice is number 10. 15 years ago, we would never have seen more general practice specialties in this list of top 10. It would have been more of the risky specialists, the surgical and procedure-based medicine. But as we head down the road, this next slide will kind of show it out. We're seeing more of the general practitioners and more of the general office practice physicians being involved in professional liability claims. And if you look down, this is the highest total indemnity paid for the past 10 years. General and family practice is number 4 on that list, having paid $668 million over that 10-year period. And what we expect is that we'll continue to see some of the more general practice clinicians being sued in there with the more risky specialties of OBGYN surgery, radiology. This is the top 5 here, and we've got internal medicine and general and family practice ranked right there with radiology, general surgery, and OBGYN. So a trend that we've been monitoring and keeping an eye on, and a trend that we expect to continue. So I'd like to talk briefly about some of the reasons for today's medical malpractice environment, and there are a number of them. The patients that you're seeing today, significantly different than the patient of 10 years ago, and their expectations and abilities are also significantly different. It's just a different patient base that we're dealing with different expectations from the medical system and healthcare system as a whole. And the societal view of the malpractice system is a driver in this market that we're dealing with. There are a certain percentage of patients out there that look at the malpractice system as a lottery. There are a certain percentage of patients that come to see their physicians that are hoping to be malpracticed upon. It's a small percentage, but we know that they're out there. It does tend to drive this current market. Additionally, the societal view of a dollar, I like to say that a buck just ain't a buck anymore. The society's perception of what a dollar is worth changed drastically in recent years, and we feel the ramifications of that in the medical malpractice world. That's had a big impact. We know that patients understand that they have full and unabated access to their medical records. And we see a lot of fishing expeditions going on from a professional liability standpoint since HIPAA has come into the world so prominently, and patients again are exploring through their medical records and looking oftentimes for things that may have gone wrong. On the list, and my personal thorn in my side, is the IOM report of 1999. I think that you all may remember when this came out. Kind of staggering for us, for the healthcare system as a whole, and also for our professional liability world. This is the report that said that somewhere between 44 and 98,000 patients die each year in the healthcare system due to medical negligence. Quite staggering when it came out. Has caused a number of issues since 1999. And a caveat in there, it has done a number of good things. A lot of the patient safety and risk management initiatives that we see going on today are as a direct result of the IOM report. From a risk prevention, risk mitigation standpoint, the report had a number of positives. But the seed planted in the mind of the American public is that the care system can be a dangerous place. I don't think we've ever gotten past that. There was a lot of skepticism when the report first came out, not the least of which was that if this was a statistical analysis, how couldn't narrow it down to something better than between 44 and 98,000. This skepticism led to a number of things, including other studies that were a little more fair to medicine as a whole, that took in a broader geographic swath and applied a much more realistic definition of medical negligence. Those reports came up with somewhere around 14,000 patients die due to medical negligence each year. And although there was a little bit of raw going on at that point in time, because these reports had on their face proven IOM report wrong, there was the problem of the fact that we couldn't go on to Good Morning America and say, no, we only kill 14,000 patients each year. And so the negative ramifications of the report are still there for us. On this list of reasons for today's environment is that shift in focus from clinical issues to service lapses. And that's a theme I think that we're just starting to touch on. A number of the trade organizations that deal with risk management and patient safety, the American Society for Healthcare Risk Management, National Patient Safety Foundation, the American Medical Association, a number of those have followed that shift in focus, dealing 5 years ago with more clinically based education programs, to now focusing more on the softer side of the issues. I was at the National Patient Safety Foundation meeting this past, I believe it was July, and the focus that had been purely clinical 5 or 6 years ago was now on patient and team communication and patient and engagement. Again, much more softer focus. And I think that there is a recognition with our ability to collect data related to professional liability and patient injuries, that if we can focus on that softer side, we can do a much better job of prevention. So the next slide, talking about the major factors that lead to medical malpractice claims. Always on the top of that list are errors in judgment and technical error, what we call actual malpractice. That clinical side does still lead the major reason behind professional liability claims. And in most cases, if you don't have a clinical error, don't see the strong pursuit of professional liability claims. You have to have some sort of clinical error to lead to the patient injury for a claim to be pursued. But it's next things on the list here that we see happen over and over again and repeatedly. New patient and team communication. We've been looking at claims data and have actually formed a relationship with the CRICO system, the insurers of the Harvard system, have a database of professional liability claim information that looks not only at the financial data but also the clinical aspects of these claims. And if you look at surgery and emergency room medicine, just in those statistics, the number two thing on the list, second only to errors in judgment and technical error, are communication errors. And the communication errors are something that we can do something about. We know that we can fix or at least improve patient and team communication. Next on the list, and then again, as I mentioned at the beginning, the next factors, a number of them will be addressed in our programs with the center over the next year or so. Next on the list is lack of patient engagement or patient orientation. We're seeing a strong focus on trying to get patients involved in their own health care. There are a number of indicators out there now that practices, general practice and specialty practices across the board, that do a good job of engaging their patients and orienting their patients to the health care that they're receiving. Patients that experience better clinical outcomes. The rolling down of that is that when we have our clinical outcomes, the chance of a patient injury and subsequent malpractice claim decreased significantly. On this list of factors leading to malpractice claims is documentation. This has been enhanced in the last 4 years or so with the implementation of EHR. There are specific risks related to documentation when dealing with electronic health records as opposed to the traditional documentation methods. And we have seen an increase in practice claims and difficulties defending those claims because of EHR implementation. We hope that as we get further on the path, those will subside. Earlier follow-up systems, it is on our list of major factors leading to claims. The loss, misplacement, or disappearance of those types of reports seems to occur a lot more often than we would like to admit. We suspect it happens a lot more often than we know about, because if there isn't some critical level or critical value on those reports and the report is lost or misplaced, no blood, no foul. And we know enough about the loss of letters where there was something critically wrong that ended up leading to a patient injury. Jousting is another factor that's making negative comments about the care of other providers and is a problem for us industry-wide. Informed consent, not taking that process seriously, going through the informed consent process with patients. Those claims are usually defensible, because what we end up with is a scenario where the reason that a patient is brain issue is a situation where the event is a risk of the procedure. But these nuisance claims, even though they're easily defensible, they are a big headache and heartache for everyone involved. And we know that if you work your way through the informed consent process properly, the chance of experiencing one of those events decreases significantly. I'm going to come back to this as we head into the development of a risk management program, because I think that that physicians in the clinic practice setting, if they can educate their staff about these issues, I think that, and I mean all staff, clinical and non-clinical staff, I think that we can see a significant decrease in patient injuries and malpractice claims just by allowing your staff to understand where we see the problems coming from. And we'll talk about it as we get into the program. So let's talk briefly about some reasons for implementing a risk management program in your practice. As I mentioned, we're increasingly seeing more suits originating in the office practice setting. Data collection and technological capabilities really have us on the cusp of realistic proactive claim prevention. The CRICO systems that I mentioned that are collecting data utilize in a preventative nature, just for example, an OB physician in the CRICO system pays 40% of what an OB physician around in Boston, the exact same geographic area, but outside of the CRICO system pays. And the reason is that the collection of this data, the drilling down of this data, is allowing medical professionals to predict and prevent claims before they come to fruition. And a lot of the development of a risk management program takes into consideration the areas where we know we're seeing potential issues coming from. The reason for implementing a risk management program is that financial and time costs of claims are significant. I mentioned to you earlier, 5 years is the average time or tail for a malpractice claim to work its way through the system. Not only time, if you are sued, having to deal with that is a significant input of cost and time. You see is that solid risk management practices promote time and financial efficiencies. There's always the impression that risk management falls into the category of another one of the things that you have to do in your office practices. And what we find is that just the opposite is true. Risk management practices tend to promote efficiencies, not financial efficiencies, but all the time efficiencies. For example, the risk management practice of trying to orient and involve your patients in their own care. Take extra time on the front end, but what we find out is that it's much easier to work through an office visit once you have a patient that is dedicated to being involved in their own health care. Last on that list of reasons for implementing a risk management program is that recent focus that I mentioned on the softer side of the science. It's showing increased quality of care, better clinical outcomes, and fewer patient injuries and fewer claims. In this instances, we've got a good, solid risk management and patient safety program in place. So, on to the meat of tonight's program. We're going to talk about the 4 steps in the management process: risk identification, risk analysis, risk intervention, and evaluation and monitoring. So on that list is risk identification. There's a number of ways that you can go about finding out where you face potential risks in your practice. One of the biggest is patient satisfaction surveys. We know that satisfied patients tend not to talk too much, but dissatisfied patients really, really talk a lot. And going through and finding out what is working and what's not working for your patients is a wonderful way to figure out where your risks may be coming from. In looking right now, next on the list is patient complaints. So right along the lines of patient satisfaction is patient complaints. Looking at the reason that you've got patients that are dissatisfied, a wonderful way to start to put your finger on where you can see the potential for a future patient injury and a future medical malpractice claim. Looking at adverse outcomes that do occur in your offices and in your practices is another way to figure out where we might see risks coming from. Incident reporting systems. I think that the further that we get down road in the new care realm that we're facing, I think incident reporting is going to be something that is required across the board. Even though on its face it seems like something that has a negative connotation to it, I think that what we'll see is that if we do the incident reporting process, we'll spot trends and to track trends that may be going on in a single practice or in multiple practices, can allow us to apply the correct risk management processes and practices to hopefully avoid those from occurring in the future. Concurrent screening falls right in line with incident reporting. Risk management assessments, on-site assessments, another good way to look at potential route there. And at the very end, we'll talk about assessments that you or your office practice manager or your risk manager in your practice can go through and look at, dealing directly with patient risks, with EHR risks, and others. I'll point those out. I think it's on the last slide tonight. And then another way of looking at risk identification is medical malpractice claim data and research. A lot of that's been consolidated in that major factors leading to malpractice slide that we just went over a few minutes ago. What we know is that very seldom do we have a shocking surprise that comes out as a reason for a patient injury and medical malpractice claim. We've been talking about documentation for the last 25 years, and I strongly suspect that we'll be talking about it for the next 25 years. we know that's a risk. We know that there are issues that are related to documentation that can lead to medical malpractice. What we need to try to do now is to have those that proper risk management process and risk management program in place to actually start doing something about those risks associated with documentation and others that fall on that major factors list that we talked about. So risk identification, we're going to do a little brief exercise. I actually haven't done this in a webinar, so it may be a little difficult, but it shows some of this video will show you some of the potential issues with risk identification out there. So some instructions here. You can see that you've got two teams. You got a team in black and a team in white. What we're going to do here is I want each and every one of you to count the number of passes between the team in white, the white team and the white team only. Count the total number of passes. And it can bounce pass, actually hits the floor, goes to the other person. It can be a chest pass directly from person to person, and but it can't be a self pass. So if a player throws the ball up in the air and catches it themselves, that does not count as a pass. So again, we're looking for the total number of passes between the team and the white team only, and here we go. All right. Now, what usually happens is I start asking people to raise their hands and tell me how many passes. I think the accurate number of passes here is 17, although there's some discrepancy. As you can see, the video starts and ends both with on the white team. Okay. I've gotten some feedback there. So I think the number there, like I said, is at 17, but that's not the point of the video. What I do now is ask, and I want everybody to be honest, ask yourself, how many of you actually saw the ape that walked across in the middle of the video? And about 90% of the American population actually missed this. I'm going to play the video again, and I want you to look at it this time. So here we go. Back and forth, and then off the right side of the screen you see the gorilla come out, turns, faces, beats his chest, and is off. This is a great indicator of the issues that we face with risk identification. Although there are a number to look about, even if we do know the risks that are out there, them happen in your practice. It's a very difficult thing to do. Lost in plain sight. This video is made just for that point, to show that you can be so focused on other things, in your case, likely the practice of medicine, that you have significant risks that are presented right in front of you and never even recognize that they're there. And that yet is another reason for going through the process of implementing a good, solid risk management process and practice in your practice. So 2 on the list of the 4-step risk management process is risk analysis. So after you identify what the risks are out there, you need to analyze the scope of the potential risk. Ask yourself questions like, is this an isolated event or is this a trend? Is this something that is likely to happen again? You do see a number of malpractice claims that originate from loss, but in the larger sense, the risks that that we see are things that are likely to happen, that are process based, that happen over and over again. And asking yourself after you've identified the potential risk, the severity of the injury or the outcome. How bad is this? How severe is what occurred? and asking yourself, what is the worst case scenario? I mean, how bad could this be? Trying to analyze these risks and see if what you've seen as a potential issue is something that you should focus time and attention on attempting to prevent. The lead that we've got here, that is a typo, so you were expecting the collagen injection in your lips and the liposuction on your hips. Probably something in the analysis process that you would want to recognize as being a problem that could occur and try to avoid it at all costs. So there are a number of ways to go through this risk analysis process. Basically, these are risk rankings, and this can be deep. I don't know that this is something that that smaller organizations undertake. Ways to go about it is the quantitative method. Basically, you look at risk as the loss value times the probability of the event occurring. So you've got extremely high loss value or potential loss value, and an extremely high probability of event occurring again, or occurring in the first place, then of course that would be something that you would want to focus attention and effort upon. The converse of that, if you have a low value and a low probability, it would be something you may have to focus as much time and attention on. You got the qualitative method. Basically determine the likelihood of the occurrence and the severity of each risk, setting a risk profile, and again, just trying to figure out what are the largest issues inside of the practice that prevent the biggest severity or that have the biggest probability of occurrence, and try and put into place processes, policies, and procedures and education, particularly for your staff, to then prevent those things from occurring. And speaking of that, we're on to number 3, which is risk intervention. There are 3 points to risk intervention, the number 3 step in the 4-step process. Number is risk elimination, number 2 is risk prevention, and number 3 is risk control. Risk elimination is basically avoidance or stopping doing whatever it is you may be doing. And although it's very difficult in medicine, the practice of medicine is inherently risky, but we've seen times where this has come into play. A lot of smaller hospital facilities, for example, have decided the risk is just too great to undertake the birthing of babies. So, OB has basically been eliminated in a number of smaller rural facilities. So that's an example of risk avoidance, not a intervention tactic that you can undertake very often, but if there's some sort of procedure or process that's presenting such a significant to your practice, it may be something that can be considered. The other 2, risk prevention and risk control, more applicable in the risk intervention process. Risk prevention is doing something to decrease the frequency, to keep an event or occurrence from happening, trying to decrease the number of times that particular event would happen. And the control or risk intervention procedures or processes that decrease the severity. So what we're trying to do there is to lessen the value of that loss, trying to keep the severity of that particular loss or issue from occurring in the practice. To throw this in, this actually wasn't in any of the materials on the CENS website, but I think that it's important to talk about a different type of risk intervention. As I've mentioned a couple of times, I kind of want to hit on it a little bit more, is risk education and risk dissemination. As you can see, each one of these starts or talks about your staff. I think that one of the riskiest situations in the office practice setting is an uneducated or unaware staff about risk management, about claims, and about professional liability in general. What we see is that in most hospital settings, all staff during general orientation have some sort of risk management education. And we see that lacks behind hospitals when we talk about the clinic setting. And this is something that we can do something about. Just the basic risk management education can make a big difference in the risk profile of your practice. Staff awareness is one of the best intervention tools available to physicians, just letting them know that these are issues, that these are problems, and that your staff, both clinical and non-clinical, play a role in helping to improve the outcomes of your patients, the quality of the clinical outcomes, and thereby lessen the chance at a patient injury and malpractice claim. Staff education on med-mal claim severity and general risk management tactics is key to an effective process. And I think a great place to start is education on the major factors leading to medical malpractice, what we talked about in slide number 12. At MIC, we do a program called the 6 Significant Factors that's aimed directly at staff. I, in my role, do a number of these programs. I usually come out and talk to our insured practices, talk to the physicians either in the morning or in the evening, and then get the entire staff together at lunch and give the program on the major factors leading to malpractice. Again, their involvement, their buy-in, a little bit of skin in the game from the staff is something that can really start your risk management process, your risk management program in your practices. And utilize your medical professional liability carriers' resources. I don't know what the exact percentage is, but I know that MMIC insures the majority of the physicians in the state of South Dakota, but professional liability carriers, even if you're not insured with us, provide these types of services, and they're usually free of charge. So look at that and call them and see what they have available to you. If you are insured with MMIC and this is something that interests you, by all means, get in touch with us or me directly, and we can provide these types of educational programs for you. So, and last on the 4-step risk management process is evaluation and monitoring of your program. Basically going through and looking at a policy and procedure review. Again, utilize your professional liability carrier. At MMIC, our website has an entire section dedicated to policies and procedures. Go through and making sure that you've got effective, attainable policies and procedures in your practice is of the ongoing risk management process and risk management program. Current screening chart reviews, making sure that if you do have unplanned or adverse outcomes, those things just brushed under the rug, that bringing those things to light, if no other place than just within the practice, making sure that everyone in your practice understands that if there's something negative that occurred, let's look and see how to fix it. There's nothing worse for us as a professional liability carrier than to see a scenario where there was what we call a near miss in an office practice setting, where a patient was almost injured because of something that went on, and the practice administrator or the physician basically wiped their brow and said, that was a close one, and then didn't do anything to prevent it happening again. And then 5 or 6 months down the road, we get the exact same scenario, but this time takes the full swing and ends up resulting in a patient injury and a malpractice claim. And aside from the clinical side, doing a product review of equipment in the physical plan is something that's all part of evaluation and monitoring that risk management program and process as it's in place. Pardon me. I mentioned I was going to talk to you briefly about conducting an office risk management assessment. I believe that these resources were placed on the website with the articles that led to this program. There are risk management assessments basically on conducting on a patient assessment, patient by patient assessment. There's incident reporting assessment, looking at the process that you have in place or a process that you could put in place dealing with incident reporting. Then there's assessment dealing with your risk management process. What process do you have now? What type of process do you want to get to? What type of program do you want to have in place? And where are you now? Where do you want to get to? And what will it take to get to that point? I mentioned self-assessment as one of the wonderful ways to figure out how at risk you currently are or how solid your program to have in place is. Those clinic risk management self-assessments are available. Also, clinic EHR self-assessments. We're seeing, as I mentioned, a number of issues related to patient injuries and professional liability claims due to EHR. And I think that that taking this EHR self-assessment would be something that would be worth your time to look and see if you have the right processes, procedures in place to eliminate or at least attempt to control the EHR risks that we see out there. That's our program. As far as the information I have for you, I really hope that that some of this information you can take back and utilize in your practices. Are there any questions that you have out there? Mark, are you still online and able to communicate?
And I just went ahead and I opened up those phone lines for those that called in. So for those who called in, if you have questions, you can ask those at this time. Okay. Hearing none, I'm going to go ahead and say a couple words here before we close out, and then we will give you another shot to see if someone does have a question. But as we kind of wrap things up tonight, I certainly want to thank Robert and thank all of you for participating. As Robert said, there is quite a bit of information that's going to be out on the center's website, and you can access all that information through the SDSMA website at www.sdsma.org. On there, you will find some briefs or articles that will touch different things that Robert spoke on tonight, and then also there's an in-depth white paper talking about the risk management process and some of those tools that he alluded to. One more thing I wanted to say before we close, and that is that our next presentation is scheduled for February 2014. The actual date has yet to be determined, so information will be forthcoming at. And that program is going to be dedicated to talking about medical record documentation and how good and clean documentation can help mitigate risk in the clinical setting. And with that, do we have any questions from our callers online? Okay, so hearing none, we're going to go ahead and we'll drop off the line. We want to again thank you all for coming. And Robert, again, thank you. And I know if anybody has questions, they can either contact you directly or they contact you through the Medical Association, correct?
Absolutely. That would be perfect.
Okay. Again, thanks everyone, and enjoy your evening.
Thanks for the opportunity.